That's lots of lungs on wrong. Yeah, right. Yeah. That's the cost of living. I am. Oh, wonderful. And so I know the value. Yes. So I know the value of how you just need that support.
Okay, we'll wait for everyone here. And I guess if I stand in this corner, I'm not going to be in the way. Yeah, I got an escape route.
Okay.
I'm okay. I don't feel too cornered.
There's a door there. I don't know if it opens to anything, but there's a door.
It does.
And I use that.
That's the elevator. In the old days, before a certain doctor rented this place and never repaired the elevator, that used to be an elevator to go upstairs.
Do any of you like some water?
Thank you so much.
So, but it hasn't worked in years.
Would you like some water?
I think I could summon some help.
A little bit.
Oh, look,
There you go.
got the magic.
There you go.
That's really fine.
All right. Well, you think are there any more reserve?
No, not really. So
Okay.
give me just 1 minute.
Okay. All right. 3 more minutes. Well, she said 1, so I tripled it.
How are you, Doctor?
I'm okay.
Good. I'm okay too.
Are you?
Kind of.
Well, that's a positive thing.
Yeah.
So I'm not going to go into it as much detail, but I will just. I'll show the slide, but I won't go into much detail.
So then just.
Okay.
This is going to be like the process of dying. Is that what that is?
Yes. What I did on it's actually got 70 slides, and the first 30 or so explain why people die.
The reason the body dies.
Exactly. You know, they're running out of energy, basically. And so I went into a lot of detail over, the mechanism, and then the narcos decided to, set everything on fire. So we didn't go any farther. So we didn't go into the planning part, the communication part, and all of that. So what I'll do is I'll just touch rapidly over the process, and then we'll go into the other part, because we've got a couple people that are also going to speak on that part as well. We've also got somebody who just finished law school recently. That she works at a notary, but she worked with me for 4.5 years, and so she's going to some questions and answers, basically. Because a lot of people have questions, and after I speak, they'll have even more questions.
Yeah.
So,
All right.
Now, is this working? Is it going through the?
Yes,
It is? Okay.
Yeah. And everybody can hear well, right? Okay.
All right.
So
If some, it's about 7 after.
With 7 minutes after the time for starting, I welcome everybody to the continuation of the palliative care presentation. And as everybody, I think, already know, this is Dr. Sam. He's going to be the first opponent for the conference. So
Presenter.
Presenter. I'm sorry. Presenter. Yes.
Yeah, she used the English Mexicanized way of, because, yeah.
All right. So welcome everybody. Thank you for being here. Thank you.
Okay. Who's going to do this? You're going to be in charge of that?
Yes.
Okay. Okay. A lot of you, anybody here that doesn't know me, has not heard me before? Okay. All right. Basically, you finish medicine and you think, okay, I'm going to do this, I'm going to do that. You're going to cure all this stuff. And of course, emergency medicine kind of has its appeal because you save lives. But the other thing that you see is you see the ones you can't save. And then you also see the people that they're not coming to you, in an emergency situation to be saved. Their life is pretty much over. And so you get some of those people that come to you and they want to know what their options are. And at first I'm like, well, that's not really what we do, but actually it is. It is part of what we do. So, all right. So anyway, end of life. I started this presentation probably about, 15 years ago, the first version of it. And it's been modified ever since. Now, in order to start something and we discuss something, we have to kind of agree on what the definitions are. And so, definition of death, you think, okay, well, that's simple. They're not alive. Okay. Well, then what is it to be alive? So definitions of death, it's not as clear cut as it seems. Go ahead and roll through all of them. But go back one. Okay. All right. So legal, it's a certificate. Yep. They're dead. Or the clean version, like you always see in the movies. Somebody goes into a hospital and then 2 slides later, it's like, oh, he's gone. That's not how it happens. Spiritual, that gets into spiritual versus religious versus whatever. And a lot of people have a different belief there. And a lot of it is belief. Now, as far as research actually being done on the existence after life, there is some scientific research on that, but most of it is not very scientific. But it is, to a lot of people, that's a very big definition. You got a question? Oh, okay. All right. Medical definition. They're not breathing. Well, no. Okay. Okay. There's no heartbeat. There's no brain activity. Warm and dead versus cold and dead. I'll just touch on that one in a second. Emotional and scientific. Disconnect from consciousness. Disconnect from consciousness would be my definition. That would be probably the most accurate definition. But to most people, really what it gets down to, it's not so much the medical part, it's this or that. It's the emotional part. You talked to this person yesterday, they're not there. You don't know if they're listening. You can't hear them. But anyway, that's a really big part of it. The loss of communication. So for a lot of people, being dead is a very emotional thing, but we're going to touch more on the medical side of it. Go ahead. Okay. All right. Complications defining death. Each one of those, I should have put them probably more in chronological order, but we've got defibrillators. So somebody's heart is completely stopped, and we would say they're dead. That person could be walking around again. Intubation, that's been over 100 years since they actually did the first intubation, the modern intubation. Mechanical ventilation, heart, lung bypass machines, pacemakers. 1958 was actually the first major one, the first one that was actually used more commercially, and it looked like a Brownie camera more than anything else in Minnesota. Transfusions, that's brought a lot of people back from dead, basically. And then just CPR. They started really in the 60s and took off. There were early versions of it, and it was more having to do with drowning and other things. But when they actually started perfecting CPR, you saw a lot of people, and I'm not talking a large percentage by any means, but if it's 3%, and I think it's probably even larger than that, and you'd figure all the people that, could receive it, that's a lot of people. I mean, even if you have 1% that would normally be dead and you saved them, 1% of everybody who dies every day, that's a lot of people. All right, so non-permanent death redefines death because they're dead, but no, now they're not. And then consciousness, which is not just a mechanical thing. It's not like a car. It doesn't just blow up and that's the end of it. Okay. All right. My definition. You might not agree, but this is kind of what I put together. How do you define when somebody is dead? Energy state too low to support vital biochemical processes. Okay? It's also irreversible. Results in an equilibrium of normally steady state processes. And I'm going to go through the next slides kind of fast because I spent a lot of time on this on the other presentation. And only a couple of you were here on the original presentation. Who was about half? Okay. All right, go ahead. All right. Steady state process would be like if you have a fountain and you're just pumping the water out of the fountain and you're dumping it in the yard, eventually it's going to run out of water. But if you have a fountain and you're pumping the water up, it goes back into the fountain, it gets pumped back up, it goes back down, it gets pumped back up. That's a steady state. You're never actually emptying the bottom of it, and as long as there's energy to continue the pumping, you have a continual cycle. Go ahead. And in equilibrium, there's a lot of things, especially in our cells, where you want a lot of something on one side and not so much on the other side. And then you strategically allow it to flow in massive amounts, kind of like opening up a dam when you need the energy to do a defined purpose. However, if you no longer have the energy to support the gradient, then everything just kind of turns into the same thing on both sides, and that's really what death is. Go ahead. All right, we don't have to go into a lot of detail, but just know that these are pumps that are run off of energy, and then in the end, different things get done. Some of these things are also part of what's necessary to make energy, and it's this big cycle. Go ahead. Hi. He's putting you in charge. And as I'm speaking, if you have a piece of paper, go ahead and write down any questions you have. Also, questions you would have for any legal questions, because we have our expert in the corner there to answer those. All right, so biological definition of human life. Go ahead, go to the next one. It's just do the arrow. Okay, so you've got energy, you've got biochemistry, and you've got order. You lose order, it doesn't work. You lose biochemistry, it doesn't work. You lose energy, it doesn't work. And I'm going to zip through the other slides, but basically, the two things you're going to lose that are going to lead to death: energy, organization. Organization mostly in the DNA, in the genetic material, especially genetic material within the mitochondria that makes the energy. Go ahead. All right, mitochondria, go ahead and go on. The only thing that you might notice, if you've ever seen textbooks where they show the mitochondria and they say, oh, it's a powerhouse of the cell, and I'll show you a picture of a powerhouse in a second. It's not like the cell has one or two of them in there. It has hundreds, it can have thousands, or in the case of the heart, it could be almost 40% of the heart cell is packed with mitochondria. So they're extremely important. They make these, we'll call it the currency, adenosine triphosphate, and everything uses it to make energy. Every little thing. Keep going. Go. Okay. And that's only to make a couple of amino acids. I mean, you talk about actually keeping the cell alive, it's a lot more. That was actually put out by a chemical company. I don't remember if it's Fisher Scientific or whoever. That goes back to the 70s. We've learned a lot more since there. All right, so life is very organized energy to run many vital interdependent biological processes. Real permanent biological death is equilibrium of those processes. Go ahead. Now, a very important thing, and I think TV is to blame for a lot of things. In fact, I don't mind the violence. I don't mind the profanity. I don't mind hardly anything. The only thing that I don't like about television and movies are the lies. I don't like seeing somebody get hit by a car and he just gets up and walks away. Okay, that doesn't happen. I mean, it does occasionally, but usually not. Usually there's going to be some sort of permanent damage. The other thing is the clean death that they always show. Somebody goes into the hospital and they're dead. It doesn't happen that way. Almost anybody who's going to die of quote unquote old age, it's a process. It's a long drawn out process. It doesn't just happen. Somebody just doesn't get sick one day and that's it. That's extremely rare. Stroke, stuff like that. But even that goes back to prior conditions. So go ahead and going back. Okay, no one just dies. It's a series of events and changes leading to death. It's like when you're driving and you're going to stop at the stoplight. You don't go all the way up to the stoplight and then all of a sudden stop. You have to slow the car down first. You cannot just immediately, stop something. It doesn't work. Neither does death. It doesn't just happen. Go ahead. Okay. Now, this is, my own definition. You won't hear much about acute versus chronic death in textbooks because it's not really a scientific term. It's a term I made up. But acute death is a series of events that happens extremely rapidly that leads to irreversible damage. And chronic is what most people will die from in their lifetime. Okay, so acute death, case 1. And the reason I put the Empire State Building there is because back, it was either late 50s or early 60s, I think it was late 50s, a woman jumped off the building. Her last name was Hale, and the photographers took a picture of her dead after she had landed, and it's actually called a beautiful death. It's actually found in some art museums, and it's because she looks quite peaceful. However, the reality is she's quite torn up just internally, not externally. Go ahead. That's her. It looks like she's all relaxed, like on a sofa or something, except that is a limousine. That's a roof of a limousine from the 50s. That is a lot of force. The number of bones that broke, the nerves that were just simply sheared, the arteries that were just sheared. It was a pretty quick death, but it didn't happen instantly. It still took seconds for her to die. Go ahead. All right, now this one you can't see real well. I mean, that's her head there. They're doing CPR on her right there. And anyway, the reason that I bring this up is because a lot of people, they're like, do not resuscitate, tattooed right to their forehead. Well, it depends. It really depends. This woman was dead for over 2 hours. I'll give you the details here in a minute. That's her teaching. That's actually, go ahead, go back. That's actually her, she's probably talking about the accident that she had. But anyway, that's her teaching after she had been dead for several hours. Go ahead. She lived again. Now, remember I said something about warm and dead versus cold and dead? Warm and dead, you tend to use up all the energy really quickly. You don't usually recover. Cold and dead, the colder you are, the less processes that are going to happen, and the odds of survival exist if there's no physical damage. And when I say, I'm talking structural damage, somebody falling off a building and landing on a car. But in her case, she was skiing. Now, a lot of you may not know, but the president before the president we have now, still the same political party, one of his promises was that Mexico was going to have a medical system like Norway. It hasn't happened yet. It probably never will happen. But the reason that he said Norway is because Norway's known for having a pretty good medical system. Anyway, she was skiing in Norway. That helps. The second thing is she was skiing with some doctors. That also helps. I mean, if you're going to do something dangerous, have your own medical team with you. But anyway, she lived again. How did she live again? None of the causes of death were irreversible. And that's a very important thing to know when we're talking about end of life, do not resuscitate, or we will resuscitate. Limited biological damage. Now, there is potential. I mean, the doctors could have killed her as soon as she got to the hospital. If they were not familiar with her case, they could have killed her trying to save her. But what they did was they warmed her up at a very slow pace. Had they rapidly heated her up to body temperature, they would have killed her. As a result, the only thing that actually ended up being permanently damaged on her, and I don't know how it is to this day, I mean, this happened quite a while ago, she does have some damage to the peripheral nerves, hands and feet. But obviously, they're still working to some extent. They're probably fairly numb. But energy was still available. So in other words, here's this woman, fairly young, probably late 20s, early 30s, and she's skiing, okay? This is not somebody that's so worn out, so tired that they can't get out of bed. She's skiing. She's doing active things. So she's full of energy. And then basically run out of energy, as is common in advanced age. There were well-trained medical professionals. That's important. And always remember, a lot of medical professionals are more ego than they are knowledge. And you walk in someplace and they're like, oh yeah, we got this covered. Maybe they do, maybe they don't. Access to medical care and equipment. Yeah, she was in Norway. Doctor familiar with similar cases. The doctor that had taken her on, he'd seen this before. That's why he didn't overheat her rapidly. The first time that he'd probably tried this, he might have killed the first patient, but he was experienced. Causes of death reversed at a correct rate. That's vital. Go ahead. Chronic death, running out of energy. And this organelle, this little thing that's inside of our cells, it can accumulate a lot of damage. Now, it can divide. It can actually get, kind of like at a junkyard where you have like 3 wrecked cars. You take parts off of this one, parts off of this one, and you make one out of it. They can also do that. You can have 3 damaged mitochondria, and they can all fuse to make one working one. Likewise, if you have a really, really good one, they can divide to make 2 or 3 more. But when these accumulate sufficient damage, roughly at about 25% of the DNA being damaged, game over. You will be dead within months. When you reach about 25% DNA damage to the mitochondria, yeah, you're down to the final months. Okay, powerhouse of the cell. That was if you're ever a biology student or even high school biology, the mitochondria is the powerhouse of the cell. But yet almost nobody knows what a powerhouse is, so why do you call it something that nobody knows what it is? So anyway, it was coined that term in 1957. The mitochondria were known to exist way before then. They just didn't know what they did. And then in the late 50s, they discovered what they did, and they were called the powerhouse of the cell. And I threw a picture in here just to show people what a powerhouse really is, because almost nobody, even in school, even doctors, they're like, oh, it's a powerhouse. Oh, it's a powerhouse. Shut up. That's a powerhouse. There's a steam engine here, and in here is a huge disc that's run off of that steam engine. Later, some of the steam engines were converted to natural gas. But we didn't have, even in the United States, rural America didn't have electricity until probably 30s and 40s. So these were still in use all the way up until the 50s. And what it is, you notice these support, these little teepee-like things, the little tripods, though they've got 4 of them. Those held bars, and those bars would shift back and forth depending on the rotation of that disc, which was run by the steam engine. And those bars would go and they would hook up to a well, and it would run the well up and down. That would pump oil or water, usually almost always oil. Thank you. She knew my throat was getting dry. Go ahead. All right, I'm not going to go into all of the different processes, and I didn't before either. But when everything in here, you're going to see different key areas right here, right here, right here. They all run off of the energy that's made by the mitochondria. Go ahead. All right, I'll go ahead and just touch on this for a second. But as far as the ATP, the actual substance that makes energy, that gives us our energy, we have about 250 grams in the entire body. That's not much. That's what, half a pound? And it's recycled continuously over and over and over again. Imagine having a cell phone from the 80s that you had to keep it plugged in and recharge it like every 5 minutes. That's kind of how we are. We have to continuously manufacture our energy. If we don't, it's game over. I mean, if you shut off every single mitochondria, as in the case of somebody taking cyanide or the gas chamber where they use hydrogen cyanide, you're basically poisoning the mitochondria, and they will stop producing ATP, and you're going to be dead in about 5 minutes. All right, just what I said before, that's a textbook where it shows, 1 or 2 little mitochondria somewhere. If they show 1, it's hundreds to thousands to millions. Go ahead. Red blood cells, that's the only one where you're not going to have mitochondria. And the reason is, if you have mitochondria, you're going to need oxygen. And the whole purpose of red blood cells is to transport oxygen, not to consume it. Liver cells, roughly around 2,000 in each one. Heart cells, 30 to 40% of the entire cell is made of mitochondria. Neuron, we don't know yet. We haven't been able to count them, but probably around 2 million per cell. Go ahead. All right, just some of the stuff that I had said before. I'm not going to go into a lot of detail on this. We'll go ahead and go on. Okay, so mitochondrial dysfunction is a very major part of why we run out of energy and can't do the things we used to do, can't think as clearly as we used to think, and what will lead to our death. Now, there's another thing that also contributes to that, and it also has its own problem to begin with. And you've heard of, plaque in the arteries, atherosclerosis, all of that. All right, so these are large arteries, and you can see it, basically building up some plaque in there. It also happens in the small arteries. We always think of it as being in the brain or in the heart, and that's because you're going to notice it right away. You have a stroke, generally going to notice it pretty quickly. You have a heart attack, generally you're going to notice it pretty quickly. It also happens in all the other organs. It can be in the liver, it can be in the kidneys, wherever. Right here, that's showing you some damage to the small blood vessels, small arteries. That's in the kidney, that picture right there. Go ahead, go on. Here's various examples of different things. Some of these are built up with plaque. Some of them are simply damaged from high blood pressure. High blood pressure over a large period of time, not having the optimum nutrition to heal everything. You get some damage to the blood vessels, and as a result, they can't pass as much through them. And then when you're talking red blood cells, which also the white blood cells for that matter too, are larger than the diameter of the blood vessel, they're not going to get through. They're going to get stuck, and that's going to create other problems. Go ahead. For example, these little white areas, they're called lacunar infarcts, and they're small little cumulative infarcts in the brain. And you'll find those in a lot of older people if you do an MRI, but they may or may not have symptoms, but they will cumulatively cause problems, and the brain just kind of gets a little worse and a little worse and a little worse. Lowering blood pressure, lipid profile to some extent. There's various things you can do to reverse this, and I suppose one day what I need to do is put together some of this and what we can do about it so that, maybe you don't have to ever go into a nursing home. But go ahead. All right, DNR, options. Do not resuscitate. All right, that's the person that wants it tattooed on their forehead or on their chest. Like, don't do it. I trust my doctor's decision. Now, that's different than any doctor's decision. And right down here is I trust any medical profession. That's dangerous. That's dangerous. Yeah. And then plug me in until the electric company goes out of business. And, not everybody is going to be up in here. I mean, if you were to ask me, I'm down here. I mean, yeah. I mean, not everybody. I mean, we talk about it. I mean, it's one of the things that I discuss a lot with the patients. But I'm still down here. I mean, I might not be able to pay for it, but that's still where I am. Go ahead. All right, case one. All right, so somebody chokes. They're eating, they choke, and they struggle for a few minutes, and they fall on the floor. Now, of course, everybody says, well, do the Heimlich. Well, not everybody knows what's happening. But yeah, that would be the thing you would do, especially when they fall on the floor. But they're going to have a pulse for a few more minutes. If they're not breathing, they're still going to have a pulse. And then eventually, because you don't have the oxygen, you're going to have respiratory acidosis, and the heart will quiver and it will stop. Okay, then the ambulance arrives. The patient's dead. They're not breathing. There's no heartbeat. You can kick them. They don't respond. They're dead. What do you want to do? Throw them out? Take them away in a bag? We can take that thing, whatever they choked on, we can take it out. And if we can't take it out, we push it all the way down in. And you think, well, that's not a good idea. It's going to go one side or the other. And as long as you can get it so that you're breathing on one lung, okay, that's enough for right now. Get them some air. Do some CPR. Odds are this patient will survive. And this patient will not have any long-term effects. So do you resuscitate? I would. All right. So basically, they couldn't breathe. CO2 buildup, carbon dioxide in a liquid is carbonic acid, blood becomes acidic, Heart builds up lactic acid, heart fibrillates, no pumping, heart stops, patient dead. We can reverse all of that. Go to the next one. Okay, causes of death, reverse. Case number 2. All right, I'll just give you a totally exaggerated case. You got a patient, older female, had cancer twice in her life. She's frail. She's been eating 1,000 calories a day for the last 5 years, which is not anywhere near enough to support life. And she falls, and they take her to the hospital. She's not responding, probably a stroke amongst other things. And then all of a sudden, her heart stops. Now, I've got the family to the left of me. I've got the family to the right of me. I don't have any paper. I don't know them. They don't know me. What are we going to do? Okay, if we've got a second, we can talk for a second. But otherwise, we generally put on a show. And we're like, okay, this person has 0 chance of recuperation. They don't even have enough energy for vital processes, let alone an extra for recovery. So what do? We're doing CPR. Yep, we're doing everything we can. If we have a DNR on that patient, nobody has to put on a show. We don't have to break any ribs. We just let everything go. Go ahead. All right. It may spare a patient some unpleasant procedures. You know, if you're conscious, you know, intubation is probably not something I do for fun. You know, CPR, I mean, you get somebody that's in advanced age, osteoporosis, you're generally going to break something, although that is necessary to bring them back. Relieves the guilt of surviving friends and family. Really, more than anything else. If you've got a DNR, you know, you've got your kids here, you've got your friends here, and they're like, well, I can't just do nothing. Well, sometimes nothing is the right thing to do. Sometimes. Oftentimes not, but sometimes it is. But you're relieving the guilt on them. I mean, so they're not going to say, oh, I feel guilty, we didn't do anything. Maybe we should have. No, they said they don't want anything. End of story. Let the doctor make a judgment about effective resuscitation, eliminates obligation of resuscitation show, just to make the family and other people, the friends, feel better. Go ahead, go on. All right, assisted death. Now, that gets into a whole can of worms. In a nutshell, it's illegal, and it carries penalties in all the states at the federal level. Now, that may change. They recently made some changes even in Jalisco that didn't make the news that much regarding abortion. But I don't know what's going to happen in this. There is an activist. She, I don't even remember her name. You know her name? Samar Martinez. Okay. Yeah, and if you look at her, she looks like she's in pretty good shape, but she has a lot of things going on. And she just simply wants to have the option. And especially in younger, healthier patients, you don't always run out of energy. There are people that die from causes that are other than running out of energy. You know, you've got a tumor eating a hole in the side of your head. You're fine, except you see your brain every day when you wash your face. Yeah, I mean, they're eventually going to die of sepsis or something else, but sometimes they need to be able to make a choice. But right now, that is prohibited. There are some options, though. But go ahead. Okay, these are just basically the laws saying that it's illegal and what they do to you if you do it. Go ahead. Okay, go back. Okay, natural life and death. There's a lot of don't ask, don't tell. There always has been. But in around 2007, the federal government, at the federal level, permitted the abortion, should I speak. It kind of let the states decide if they wanted to permit it or not. And at that time, the only place that took anybody up on it was Mexico City. Mexico City permitted it. And then I think it was Puebla, Oaxaca, something like that. And then a few other states, and Jalisco's there now. But of course, when this happened in roughly 2007, there were billboards. I mean, the religious, I'll go ahead and say religious nuts, really had a heyday, and they put up big posters and all sorts of stuff. But the result of that was that over half the states in Mexico modified their state constitutions to say that life is protected from conception to natural death. Okay? Explain natural death. Does somebody just get old and go to sleep and doesn't wake up? Okay, that would be a natural death, I suppose. But there's a lot of cases, and I could give you a lot of cases that are not natural deaths. And I'm not talking about, violence or anything like that. I'm talking about mostly cancers. There's other things besides cancers that can just make your life miserable. And so they really did a terrible job at defining what natural death is. And I don't think they know, and I don't think they care. But anyway, natural death is a result of failure to thrive. You usually hear that in children. You also have that in older adults. Somebody that needs 2,000 calories a day, they're only getting 1,000 calories a day. They also need all the nutrients, all the minerals, all the macro and micronutrients. They're not getting that. They're just going down, spiraling down and down and down. Go ahead, the next one. All right, now causes of natural death, failure to thrive. All right, in cancer, you have metastasis, you have malnutrition, you have various things. Chronic lung disease, okay, respiratory failure. Chronic renal insufficiency, okay, the kidneys stop working. There's a whole bunch of things right here that, yes, they will fall into the category of natural death. But I can tell you, not everybody who gets sick is going to fall into this category. And so there really needs to be a little bit more of an open discussion on this at the top level, at the legal level. But go ahead. Palliative care. Now, palliative care, a lot of people kind of confuse that with terminal, but there's a lot of doctors that practice palliative care, and they don't even know that they're practicing it. You go to a doctor and you have, your knees hurt. So instead of them actually looking to see why your knees hurt, it's like, oh, here's some aspirin, go home, have a nice day. That's palliative care, because you're not actually solving a problem. You're only making it less bad for the person. And we often refer to palliative care as something that happens when somebody is dying, where you're not treating the problem. You're not treating the cancer. You're not treating the heart failure. You're not treating the respiratory failure or the kidney failure, but you're making them comfortable in their last days. And so in palliative care, I mean, if somebody has enough money, you could basically extend their life and also extend the quality of their life. It doesn't always happen, and it's usually expensive, but it can be done. But then we usually get into the dilemma, quality versus quantity. You could live a little bit longer and suffer a little bit longer, or maybe not quite as long, but it'll be a good quality of life. For example, somebody that doesn't have enough energy to even hardly get out of bed, usually I'll say a cancer patient, for example, because I am thinking of a cancer patient in this case. He had no energy whatsoever. Well, rather than just kind of like, okay, just rest and just, stay in bed until you die, we actually gave him amphetamines during the day. So he had a couple of good hours that he could go out and do a few things, and then he'd come back home and go to sleep. Did it shorten his life? Probably not, but it could have. But at least he got to do a few things while he was still alive. And there's different things you can do to help. Now, if it's pain, not everybody that has cancer will have excessive pain, but it can. You can have pain, you can have anxiety. You have somebody that's got respiratory failure, somebody that can't breathe, you could believe they're going to have some anxiety. You could have somebody that they're sitting there, they're just so stressed because they can't breathe, and then they require more oxygen, which they don't have, and simply giving them a mild sedation. I mean, you can give more than that, but even sometimes just a mild sedation, they're relaxed, their oxygen saturation goes up. You extended the quality of their life. Go ahead. Okay. Many medications commonly associated with failure to thrive. I'm not going to go into it, but you can see the list of things on the left. There's a lot of medications that are given. Most medications have side effects. Some of those side effects are good. Sometimes I'll use medications only because I want the side effect of the medication. I don't even care about the main thing it does. But usually, most of the medications that are going to be given to terminal patients are going to have some very negative side effects. We could try to minimize those, but they're going to happen. Go ahead. Okay, professional judgment. All right, based off of education, based off of culture, based off of religious beliefs, based on knowledge, based on experience, based on your wishes. Now, I've got a few patients that are Jehovah's Witness. Okay, I don't believe what they believe, but if they tell me they don't want a blood transfusion, I will say, here's the facts, which they already know, this, and this, and then, do you want it? Do you not want it? I don't want it. End of discussion. The patient's in charge. I mean, it wouldn't be what I would do, but I'm not the patient. And so we really need to listen to the patients. There needs to be a lot more listening to the patients in the hospitals. I'm not sure if being in a Mexican jail or being in a hospital in general is worse. I mean, basically, you go in, you take away your nice clothes, give you some crappy clothes, and then they tell you what to do and what you can't do, and it's not a nice place to be. But there really needs to be a lot more listening to patients. And that's going to require that the patients actually speak. And they need to speak while they still can. They need to choose who they want to speak for them. And of course, from our end, as doctors and other professionals, we also need to possibly, what I want to say, make you have questions that you wouldn't have thought to ask, if that makes any sense. So we need to throw out some information so that you understand the process. Understanding plus communication, that's really going to make the best possible outcome. Planning is extremely important. Go ahead. Okay, I'm just going to throw this out real quick because this is very important. There is a document that is updated every so many years, and it's put out by the federal government. And it's not a law, it's not a constitutional amendment, it's not a norma, it's not a regulation. It's called an acuerdo. And that would translate to agreement. And if you have any extra input on this, speak, because you know more about this than I do. But it's a document, and it was written by the federal government, and it's written regarding palliative care. And in this document, part of it, which is a separate document, as she has told me, one of it gives the guidelines for palliative care. And it's got a lot of good recommendations in there. Then it's got this acuerdo that basically says a lot of things, but two major things that are extremely important is in Mexico, we have the double effect. And this acuerdo, they specifically said that it is not euthanasia in the version prior. This latest one just said that it's a legal option. Double effect is not something you're going to get an option to do very often. But let me give you an example of it. When you've got somebody with epilepsy, you give them medications to slow down the nerve impulses. And usually, not always, there's several ways to do it, but usually it's going to block the sodium channel so that the nerves cannot operate as well. And if you take an epileptic medication, they make you stupid if you take enough of them. I'm not saying, that epileptics are stupid, but if I give somebody who's not epileptic a normal dose right now, you'll think, I can't, it really slows your brain down. So let's say that I've got somebody that has a lung cancer and it has metastasis to the brain. They're starting to have convulsions, which isn't always going to happen, but sometimes somebody just faints, and that's the first sign that we know that they have cancer somewhere else because they have a tumor in the brain. So we give them an anti-epileptic drug to control the seizures. Okay, it's fine. They adapt to it so that they're not so sluggish all the time. But then as the tumor grows, I have to give them more medication and more medication. And then one day I've got to make the choice. This patient is in a seizure that's basically going to kill him. It's going to cause brain damage. It's going to cause him not to be able to breathe. And so I can give a very, very high dose. What's another very important organ in the body that has sodium channels? The heart. You can kill somebody by giving them too many anti-epileptic drugs. So let's just say that I give them a dose to stop the seizure, even though I know, which you can't know, because there's, between this patient and this patient might overdose on this much, this patient could have this much. So you never know. But let's just say that somehow I knew that this dose was going to kill the patient by stopping their heart, but I'm giving it to them in order to stop the convulsions. That would be the double effect. In which case, even though that patient died because I gave them a very large dose of medication, it was given with the intention of stopping the seizure. That's a double effect. That's just an example of it. A lot of people would say, well, morphine because of the pain. Believe it or not, it's pretty hard to overdose on morphine. I know there are some people that can, but the average person, it'd be pretty hard. All right, the other one, go ahead. Okay, the other one is terminal sedation. And that's a really important, I'm going to say loophole, but it's not really even a loophole. But it's a very good option, because let's say you've got somebody who is suffering and they just want to be put out of their misery right now. Okay, that's risky and it's illegal. But I could put them to sleep for a week. That is legal. If pain and suffering, well, actually it says pain and or suffering, cannot be alleviated by any other means, terminal sedation is a legal option. And that basically keeps a lot of people out of trouble. Now, how much medication is required to keep somebody asleep for a week, 2 weeks, 3 weeks? Depends on the person. Sometimes this much, sometimes this much. And of course, the last thing you want is, oops, it's been a week. We ran out of medication. That's no. All right. Now, I'm just going to touch on this real quick. This is more for the government hospitals. Now, one of the things, we just went to a conference over the weekend, well, actually Thursday and Friday, it was put out by the government. And it had to do with terminal care, end of life and stuff. And some of it was, like I said on the last presentation, that was 45 minutes and I'm never going to get back again. It was a terrible presentation. But some of it was extremely useful. And anyway, we've got, for example, hospital civils, which are, I won't say free, but they're paid for by government and other things in Guadalajara. And there's two main ones in Guadalajara. There's, I don't know when that new one is going to be built, the one on Periférico South. I mean, I think it's, yeah, it's pretty close to being done. There's going to be one as you go just past the airport, and you take a right, which is Periférico Sur. It's been in process for the last few years, and I just asked her, and she said it's almost done. And according to the governor, there's also going to be 2 more in the state. They haven't even started them yet, but Puerto Vallarta and Ciudad Guzman are also supposed to be getting some of these hospitals. And one of the things that I guess we should have known, it seems obvious enough, but until he actually said, I think there's, and Mari, you would know, you were probably paying attention more than I was. What do you say, 7, 8 states that use the civil hospitals in Guadalajara? Yeah. So it's not just Jalisco that's using those hospitals. That's why they're extremely full. And you generally don't want to go there, not because they're bad hospitals, but because there's a line of people that want to go there. And so if you have chronic degenerative disease, dementia, whatever, you're not going to be the top one in line to get in. But the state of Jalisco, and there's a few other states as well, do have a system where you can do something with them and kind of like pre-register what you want at the end of life. You do want resuscitation, you don't want resuscitation, you do or don't. And probably, even though most of you probably will not be using the hospital civils, although some of you might, there is a cancer system in Guadalajara that has helped a lot of people that could never afford I'm not saying it's great care, but they got medication that they could never afford. And so that is part of the state government system, and it would have these forms as well. So if you do go into one of those, or you think you might, or if you're just bored one day, you can do the paperwork ahead of time. Now, this is not going to pertain really to the private hospitals per se, Although I guess they could pull the document. The regular one would be better. Okay. All right. Okay. Okay. Go ahead. Go ahead. All right. Go ahead. Yeah, keep going. How did that get back in there again? Go ahead. No, I think you're going backwards. No, you're not? That's weird. Okay. All right. No, it got in there a couple of times somehow. But anyway, the thing that you can do here, and most people are aware of it, but they still may have some questions, is you can get a notarized document. Now, if you write something and you sign it, it doesn't carry much weight. If it's notarized, which means somebody actually saw you do it, they witnessed it, they saw your ID and everything else, and they put their magic seal on it, then it becomes valid. And a lot of people think, well, it's just to have a do not resuscitate. It can be whatever you want. I mean, if you say, I do want resuscitated, I do want this, you can change it. I mean, you don't have to even though they've got a copy paste system there and it says almost the same thing for everybody, you can modify it. I know one person that it basically says kind of standard. It says, I don't want, if I'm incurable, this and that, I don't want to be intubated. I don't want to have all of this. And they added on there, if I am intubated, I want to be extubated, and so on and so forth, which is different because a lot of people won't have that document at the time. I mean, unless you're carrying it in your back, pocket, you go to the hospital for something, you might not have that document with you, in which case they may already intubate you. Now you can show them the document. The document says, oh well, you got to pull it back out. So you can make these documents say what you want to say. And I think I'm going to, what? Go ahead.
No necesariamente tener una enfermedad como cáncer, pero puede ser también una enfermedad con mucho tiempo de anticipación.
Okay. Yeah. What she's saying is that also for dementia, if somebody has, or they're in the start of dementia, they can go ahead and do the document. And because this thing, as far as the intubation and all of that, it doesn't necessarily always have to apply to somebody that has that kind of a disease. If it's, say, dementia, you get to the point where somebody with dementia, they're not eating. They don't remember to eat. You can put on that document, I do not want to be forced to eat. I don't want to be, you can make it say what you want. And with that, I think I'm going to hand you over to the expert in that area for some questions. Does anybody have any questions for me? Go ahead.
This extubation.
Uh-huh.
So if you don't want intubation, but you get intubated anyway because they don't know that you have this no intubation, you have to have written, notarized directions for extubation also?
Yes, or a family member or somebody that's authorized to say that. And so it's probably better that you do add that into the document. It says, if I'm already intubated, it is my wish to be extubated. Now, let's say that it's from trauma, and because you have 4 broken ribs in 4 different places, in which case you need to be intubated for a few weeks, and then you would walk out of the hospital. In that case, you leave it up to the judgment. But usually what the document says, that if I am in a curable, situation, that's where it applies. And so, yeah, you could put that in there. And the one that has more experience with that is her.
It's a medical directive, and you can write everything that you wish when you're capable of taking care of this medical decisions.
How would you know all the things you would need to miss?
It's a general medical directive.
I have one that's made at a notary. And I'll go back and look at it. But my memory is that it's fairly general. It doesn't list a lot of different situations.
Exactly.
Possibilities.
Exactly. What she's saying is she has one, and it's very general, and they are very general. Even though there's some that have multiple pages, most of them are very general, and it's really up to you to get what you want. Don't just say, "Oh, that looks good." Ask questions. Ask lots of questions.
Well, here, I would like to add up something onto that real quick. One of the things that I've been doing lately with my patients is when they have a power of attorney, I ask them to have an extra power of attorney for me and a family member or a close friend that they trust for medical decisions. The reason is because at the end, when someone ends up in the hospital, it could be for trauma, it could be from other different situations. I will have a guideline already pre-assigned with my patients saying, these are my wishes. If it's something of this situation, this is what I want you to do. And if it's something on this situation, this is what I want you to do. So basically, it's a guideline for me to follow up the lead of your wishes. And it's a legal document. It might cost a few extra pesos, but for sure it's trustworthy. It's worth it. And this, you can do it not necessarily with a nurse or a doctor. You can do it with a very close friend or a very trustful family member, so they can follow your lead, because you might not and you will not be in the condition to make the decisions. And with only one paper, I have seen a lot of miscommunication happening. One case is a couple of months ago, there was a lady who was taken by a close friend to the hospital. The friend was not in the power of attorney, but she didn't know that she did not want to go to a hospital. So you have to notify your close friends and everybody who has your power of attorney, so they know and they can guide everything through that person. This lady, she had internal bleedings all over after a bypass. And after months of fighting this, plus cirrhosis, she was weak. She was not. She was malnourished, and her wishes were she didn't want to do anything else. At the hospital, they retained her because they didn't know her wishes until they got the power of attorney, and it took about a month and a half after staying at the hospital. And her friend couldn't do anything because she was not in that document specifically. And by the time that the family members came and requested, this is what she wants, she was already intubated, and the doctors didn't want to do the release from the hospital as the wishes of the patient was, because they were already following the medical guidelines. And legally, they cannot just extubate her and get her home. It has to be a process, and all of this has to be set since the beginning. And that, I hope, answers your question. Yes.
What she's talking about is the medical directive that you get notarized from the notary. And you're going to get an original, and then you can make as many copies as you want. But unless it's an original or a copy from them with the magic little hologram on it, it doesn't count. What?
You can get several originals. You can get as much.
Well, that's what I'm saying. That it's
originals, not certified
okay.
Okay.
But it's going to be a fee for each one. No? Okay, she's saying no.
Alrighty now.
So get as many as you can.
At least that's a notary number 2. So that something extra already. Okay.
So certified.
Originals.
So she's saying original. Now, certified copy also carries the same weight, but they do charge for a certified copy.
Mm-hmm.
She's saying that you can get multiple copies multiple originals without an extra fee. I don't know how many, but you want one for you want one for the doctor, somebody that, one of your friends. Keep in mind that your friends are not always going to be right here. So with another friend, get 5 of them.
Yeah, I recommend you that if you have nursing service or if you have a doctor, your primary doctor, they have to have that. Otherwise, it's almost impossible for us to guess what's coming. Is there any other question?
just want more information about this, a Seville hospital, special hospitals. What are they? Offer a special service? I wasn't, I'm not familiar.
Okay, the hospital Sevilles, they are, I wish I could say exactly who funds them. I know a lot of it is government, but it's not completely government. But they are pretty much run by the government. They're also associated with the University of Guadalajara, which is also a government hospital or a government university. There's the original one, which is named after the person. It was Antonio Alcalde, something like that. Huh?
Fray Antonio Alcalde.
Yeah.
And the other one is Juan Ime Chaca.
Yeah, but they don't usually refer to them as, by the names. They just say the old one and the new one.
Okay,
And
Seville is the name.
yeah, well, it's the Seville hospitals, yes. And the old one, they both have all the specialties. But depending on, you may get more children going to this one. You may get, heart transplants in the new one, not the old one. But they all do have an overlap of every specialty. These are very large hospitals. The old one, it's older. I can't tell you exactly when it was built, but I'm going to say well over 100 years ago.
Wow.
Yeah. Yeah, it's old. Now it's been, redone a few here and there, but parts of it probably still are old.
But the care is what?
The care is there. Now keep in mind that we're not talking, private room, air conditioning. You may not get all of that stuff. I mean, you go there and through the triage, you might be in a room like this with 40 gurneys. It's like I say, it's a very with all the states, all the people that want to use it, it's taking up the gap for a lot of people that wouldn't have any other option. But at the same token, some of the doctors, not all of them, you get idiots in any hospital, but some of the doctors are really good with a lot of experience. So, sometimes if you can't figure something out, that's where you want to go.
In fact, some of the best doctors in Guadalajara are from the civil hospitals. Yeah.
Yeah, they see things that a lot of people would never see in their life.
Okay, is there any other question for Dr. Sam?
Any questions on as far as the notarized document? Anything there as far as the medical directive?
On the not resuscitate notarized document, have one. Like we have one, but we've had it for quite a few years. I have no idea what it's specific about. So would it be good to consult? Who do you consult?
It would the notary, but we could also look at it before you go there and give you some ideas as to what you might want to put on there or what you want to take off. As far as a date, I believe it's good forever, isn't it? Okay, it is good forever. However, sometimes you will put on there somebody who you want to be in charge, and you can put more than one, which in these states, usually they don't do that very often, although sometimes they do. But a lot of people have 1, 2, even 3 people on there, and let's say that 2 of them are, died already, in which case you want to redo it. You can't just simply say, oh, what's it cost to just edit these names? You have to do a whole new one. And whatever the charge is on that one, which is how much? Around 3,000? Okay. Yeah, she's saying around 3,000 right now. But if you do have questions, if you have one and you want to see if there's anything that you can do to make it better, you can talk to me, you can talk to her.
Does her have a name?
Her name is Andrea. She is a lawyer.
She also has some cards.
Yes, she's a lawyer, a really good lawyer that works with us and helps us out with patients, or also for freebies sometimes. She's actually very kind. And her name is Andrea. She works at Notary number 2 at the moment, and that's how she gets to know a lot about all this situation. Yes.
Yeah, she also has an office upstairs across the hall from mine. Yeah.
We try to have the whole network kind of together. So, All right. If there is if there is no more questions for Dr. Sam, I would like to thank him for his presentation. That was very complete, and I think we have a lot of information from there as far as palliative care in Mexico. And we thank you so much. So,
Thank you.
You mean you're complete? Are you complete? You're not coming back for part 2?
We can do part 3.
we can do.
No, I think what I want to do, now I don't know how many people would be interested in it, is basically going over some of the things that could be done to try to avoid or prolong life, so to speak, to avoid the problems that I was talking about as far as the, to some extent. I mean, you can't do it forever, but there's a lot of little things that people do or don't do. They take a medication that interferes with this, and if they would just take this with the medication, maybe they wouldn't have all the complications. There's a lot of different things that can be done where, people don't have to die as soon as some people will die. Right. But the biggest one is activity. That's the biggest one. That's a huge one in so many ways. I mean, retirement can sometimes be the worst thing anybody can do. Although if you had a really bad job, getting out of there is a good thing too. But
But then I need to ask this question because I am just a little bit. I'm just a little bit confused as to how palliative care and hospice works here in Mexico. I'm used to hospice and palliative care in California. And if someone's on hospice, you have said you do not want any more treatment. I just want to stay comfortable and let me die. Someone on palliative care can have a terminal diagnosis, but are still eligible to continue treatments, whatever they may be, chemotherapy, radiation, whatever. So there was a distinction for me.
Yeah.
They both have terminal illnesses, but palliative gives you permission to continue all of your treatments. Hospice says, no, you said I'm complete.
Yeah, no, she brings up a good question about the distinction between palliative care and hospice. And in the U.S., there's a big difference to a large extent because one is usually paid for by the insurance company. But for example, palliative care, you could have somebody that has, let's say, emphysema, and they can be on quote unquote palliative care for 10 years. It doesn't mean that they're necessarily going to die tomorrow. In the U.S. and probably a few other countries, they usually put the hospice at the 6-month period, if I recall correctly. And so it's somebody that we're going to say, you're going to be dead in 6 months. Now you can have hospice. Well, they might be 2 months. It may be a year. We never know for sure. But anyway, they do want you to make an educated guess saying that person is down to, 6 months or less, in which case you totally shift you go strictly to a palliative and without any treatment for whatever they have, in which case it's just pure comfort. And you plan on them dying soon. And palliative can be a very long thing. But often they're used interchangeably. They are not the same thing. And mostly it's the imminent death that gives you the definition of hospice. So,
because even hospice, after 6 months, we would say you graduate versus being kicked off. But if you don't die in 6 months, time's up.
Yes. Yeah, no, we don't. In Mexico, you're going to pay for a lot of this out of your pocket. Mm-hmm. And for example, there was, I think it was MetLife, if I recall correctly, and they were sold a policy that was supposed to be the premium, it's going to cover everything. And the guy, he basically was having some trouble as far as he ran out of energy. And so we did a few tests on him. Bottom line is he had cancer. It started off being lung cancer. It was right behind the heart, so it's kind of hard to find. But anyway, he had lung cancer with metastasis. And so it would cover all of his treatment. However, it would cover something stupid. It was, I may be off a little bit, but I don't think I'm off much. Something like $5 a day for home nursing care. Oh. It was something ridiculously cheap. And of course, when we told the agent, he goes, well, they knew what they were getting. So, yeah, but so you're not going to get a lot of hospice coverage per se in that. And even if you do with the insurance, they're going to want their facturas. It's going to be more of a pain to work with them than it's worth. So, in some ways, you kind of want to save up a little for this, but it is a lot cheaper. I mean, you can have nurses in home 24 hours a day. We can have infusion pumps at your house, all of that stuff, cheaper than you could even, yeah.
Thank you so much.
You're welcome. And I would like to add up just a tiny bit on that. We just went to a conference for palliative care in Guadalajara, and basically what we have learned, they call it a gossip. We all like gossips, right? And a doctor was mentioning that we were going to have very likely in Guadalajara the first hospice care by the government in next coming year. So it's a
The
newborn.
first brick has been laid.
Exactly, the first brick has been laid, and it's a newborn. In terms of a new type of care in Mexico, because at this point we only have palliative care, but there is also a lot of misinformation about palliative care. Like everybody, tries to put it as, oh, you go for palliative care, you're going to die. And that's not the reality of palliative care. The reality is palliative care goes from when you get the diagnosis, because we're going to treat pain, we're going to treat grief, we're going to treat everything with a multidisciplinary team that works along your needs. And in this case, for hospice specifically, we're just getting, we're in diapers in Mexico still, but we're working on it. So a lot more population in the nursing and medical field are getting involved on the topics. And that's very interesting because we're getting more and more and more people, to help around. Also, another thing that I was going to say, it's another gossip from Chapala Medical Supply. We are putting hands-on work to get an association working in the lakeside area for palliative care. We're still in diapers and that too, but we are trying to get, some funds and everything to help people with low
They don't have the resources.
yeah, they don't have the resources money wise to get to the care that they need. And it's more likely for Mexican population, but it is also for foreigner population, because we know, as everything gets to be known in the area, there is a lot of people that they come to Mexico and they don't have a plan. So we can help all that people as well. Okay, so all right.
Yeah, the hospital that she's talking about that they laid the first brick, it's going to start off just being a 10-bed hospital. It's going to be very small, and then if it works, and it will, it'll be upgraded to 20, which is not going to be anywhere near what is needed, but at least it's a start, and it's a recognition of the issue that we do have. Yes. At least it's not being ignored like it has for many years. You get oncologists. I mean, they're terrible about this. So you get specialties that their specialty is looking. They got little blinders on. They only look at one thing, and you'd be surprised how many people are sent home from the hospital from their oncologist with the worst pain management. Just unbelievable. It's like, well, you can take this. You can have this crappy opioid. It's mainly just going to cause constipation. We don't want to give you anything addictive. But, yeah. So it's necessary that this is finally being recognized and being addressed a little bit.
Yeah. So it's one step at a time. Okay. All right. So if there is no more questions for Dr. Sam and no more comments, I would like to introduce you to a beautiful person that we happened to meet very recently. And to me, it's a pleasure to introduce you to Bonnie González. And also I want to go, forward to this. She wrote a book that it's beautiful. Please, I beg you to read it. Okay. It's just wonderful. Bonnie, would you like to introduce yourself, please?
Oh, sure.
It's called Blindsided by Grief.
Can I stand?
Sure.
I'm gonna time it myself.
It's okay. Let me start searching for your,
There
you go.
Schedule here. Just 1 second. I want to be a thoughtful person, which I usually am. So I'm just making sure that I am aware of the time. Oh, you can't hear me? For that? Okay. Can you hear me now? I could probably speak without the microphone.
Oh, actually,
I had 4 kids and 2 husbands, so I don't know who I yelled the loudest with.
if you want to just put it over here, because that is because we're transmitting a live time.
Oh, my gosh, you didn't tell me that. Maybe you can tell me.
Sure, I can do that. Let me go on and. You're welcome. There you go.
Gracious. Alrighty, finally. Why don't we all just do something? Let's just all do what we do best. And that's take a deep breath and just let it out with a smile. Just smile. And one more, those beautiful deep breaths. And another big, lovely smile. And just take your hands, just shake your hands a little bit. We've been sitting and listening to a lot of information that has us thinking, and we're just in our head. So let's just come back to our bodies. If it feels good, put your hand over your heart, hand on your belly, and just one more breath. Wow, and I call it arriving to this moment, because this moment is new. So, she asked me to introduce myself. So my name is Bonnie González. I am a grief coach. I'm a certified grief educator. See what else? I'm a registered nurse, a religious science practitioner, and a licensed soul collage facilitator. But the most important is that I am here with you in this moment. And I want you to congratulate yourself for showing up today. Just give yourself a pat on the back and attaboy, because we are here discussing 2 things that are the least talked about things in our culture. I always thought grief was the least talked about subject, but I have come to learn in my studies and practice that death is the number 1 not talked about thing. And I always thought that, but that's an error. Death is the number 2 thing that we don't talk about. Grief is the number 1 thing that we don't talk about. And there's a slide there. so I won't bore you with too much about my life. Just that I just want to say that I I haven't suffered anything. I have endured a lot of losses in my life. And mine all started back in 2020. And I bet you so many of us have not unpacked the loss of 2020. Just think about 2020 for 1 second. What transpired? What was your life before that? And so for me, by the time 2020 came around, I had lost my mother like the year before. My dear brother-in-law, 49 years old, outside sunning himself and dropped dead. And they didn't do an autopsy, but he had been treated prior for pulmonary embolus. So they just assumed that he had an embolus and died. So that was just really traumatic. And then my younger brother in 2020 died, not from the pandemic. He died from pancreatic cancer. Then my oldest sister had the nerve to die, a few months later. And then we got this notice that we were living in a beautiful house in San Francisco. The owner wanted to sell it. It was only like $1 million. And I thought, maybe that's not the time at this age to have such a big investment. So we moved to Ireland, from California to Ireland in the middle of the pandemic. I get to Ireland and it's like, my gosh, what is my life? I just couldn't believe it. By day, I was the household cheerleader, but at night, I was just crying myself to sleep. So many losses. And when we think of loss, I'll ask you that in a minute.
when we think of grief, the first thing that we think of, tell me, what is the first, I keep thinking this is a microphone. Down. Tell me, what comes to mind when you hear the word grief? Just yell it out.
Loss. Loss, like you said, loss.
Okay. Anyone else? No?
Sad.
Sad. Okay, sadness.
Painful.
Lots of pain, yeah. So that's where I found myself, in just the midst of pain. I felt like I was drowning. There was no one to help. And all of those losses combined, moving and leaving behind a lifestyle, the list just goes on. I found myself having a dark night of the soul. Anybody familiar with that term? A dark night of the soul? A dark night of the soul is when suddenly the life that you have, that you've been enjoying, suddenly no longer brings you joy. There's just no hope. Nothing makes you happy anymore. You just can't. It's like, what is going on? That's the first thing I hear from my clients. What is going on? And a dark night of the soul, the best way I can describe it is, I think this was from Michael Beckwith. He talks about a dark night of the soul being that state that you're in. You're no longer the person that you used to be and having all this fun and gaiety, but you're here and you're not the person that you're becoming. So you are just in the state, I call it the holy chrysalis, that you're in the state of morphing and transforming. And it was through my own dark night of the soul that brought me to this grief work. And this grief work, when I am talking with a client, all burners are fully lit. I feel like I'm really living my life on purpose and just really now a joyous life. But I had to go through all of that to get to now. And that's why I say grief is very, very transformative. So we'll just go to the next slide. So I just want to ask you, what's your story? Who taught you how to grieve? You know, we don't remember I said death and grief are the two most not talked about things. If you don't talk about them, you don't have language. You don't have language to express what it is that you're feeling. You don't have the language to comfort someone else. So we need to start. And please, I don't want anyone here to feel that, oh, I should be doing better. Oh, I should not be doing that, or I should not have said that. It's like, no, it's like you didn't know. You just did not know, because that's why I asked. Just take a few minutes. Oh, we've already done that. We'll go to the next one. Yeah, just take a few minutes and think about how you learned about grief, how you learned about death and dying. And this is what I want to explain so that you have a clear picture of what loss and grief is. And loss is any expected or unexpected occurrence where you can't go back to the way your life was before. And we all know that death is the biggest hole we'll ever have blown through our hearts. Death of a loved one, of a friend. That is the biggest loss. And we cannot go back to the way life was before. But then think about a divorce, loss of a friendship, a diagnosis, which we're talking about here with palliative care, that you've received a diagnosis or your loved one has received a diagnosis that your life can't just roll back and be as it was before. Natural disasters, birth of a child, puberty, graduation, job promotion. Oh, I guess I should put in there the aging process, that losing mobility for me, that feels to be the biggest one. So that is the loss. And in turn, it puts us into grief. And grief is just a collection of normal, natural emotions that can follow a loss. It can include sadness and anger, but can also include numbness, confusion, guilt, anxiety, and joy. So just know that those are the emotions. And the reason I wanted to make that so clear, because if you leave with nothing else, I want you to leave with the knowledge that it's not just death that causes grief. We have other losses that causes us grief. And since we don't talk about it, some people are very confused as to why they're feeling a certain way and certain things keep coming up. And when I sit with them, we come to find there's always some loss or losses that will have led to that. So before I get to this part, let's see where I am with time. I want to say, are you aware that there are different types of grief before I move forward? Anyone? Okay, well, let's see. Maybe I can go in alphabetical order. There's anticipatory grief, grieving what has not happened. And that is so true with palliative care. People are grieving that my loved one is going to die, or the other thing I refer to as living losses is where nobody died, but you know you're going to get laid off in a couple of weeks. Your house is in foreclosure. You know that you're going to lose your home. So that's anticipatory grief, that you're anticipating a loss that hasn't happened, but it feels truly, truly real. And the reason I wanted to mention that for palliative care is because when we have that anticipatory grief, people are really in limbo. They're loving their loved one and they want to keep loving them, but they know that they're leaving. And most clients feel like, if I accept that he's dying, then I don't love him as much as I thought. And it's like, no, you are in that in-between stage and it's hard. And we'll talk about things to do with that. But anticipatory grief. And then there is collective grief, which we all know about the state of the world now. It's not what it used to be. So many people, oh, I miss this and I miss that. And then you have cumulative grief. And just because you have one doesn't mean you can't have the others. That's what makes grief such a complex ball for you, because you can have the anticipatory grief. You can grieve, you know, the state of a natural disaster that has happened. And then you have what's called cumulative grief. That's a lot of things happening at once. You know, you're ill, the house is foreclosing, your grandkids are sick. So you can have cumulative grief. And then there's something called disenfranchisement grief. Disenfranchisement grief. And that is the grief of, say, your dog died, but people are, oh, just your dog, you can get a new dog. You know, that's, oh, it's your grandparents. Oh, they were old anyway. That's, you know, that doesn't matter. I had some disenfranchisement grief when my first husband died, and we had been divorced for 25 years. And I was so like just torn apart. It was like a chapter of my life that was over. So those are the different categories of grief. So now back to this one. If we were in breakout rooms, just take a minute and just think. You don't even have to answer. It's like, how do you grieve? Yes, how do you grieve? Where did you learn how to grieve? Where did you learn? And the other is, if you don't grieve, why? And next slide. And so with that said, it's loss is what we experience and grief is what we feel. You need to feel it to heal it. Think about it. You can't heal what you can't feel. If you don't feel anything, okay, there's nothing to heal. But if you're feeling it, if you're having emotions coming, that is your mind and body and soul saying, now is the time that you can confront this. You can be with this. And again, know that it came to pass. And what I mean by that, what grief you're feeling came to pass and to not be suppressed. It came to pass through you. Unprocessed grief is bad for your health. Talk about all the list of death and dying. that is one thing that can definitely, it just affects so many parts of your body, especially your brain. And know that what you resist will persist. So if you have grief, know that this is the time to move through it. You're the next. So here's what I know for sure. I call them my 3 pillars of starting that healing process from grief. is that grief needs to be heard. Grief needs to be validated, and grief needs to be shared. So grief needs to be heard, validated, and shared. That goes with any of the types of grief that I mentioned. They all have to be expressed. You have to empty yourself of it. And these 4 friends, these are the 4 friends that I say that we all need when we're grieving. And this is from Timothy Summerlin, for the 4 friends that you need to help you move through grief. And you need someone is the relator, someone who has suffered the same type of loss that you have. Somebody that, my sister that I said her husband was outside sunning himself, died suddenly. And we went to a widow's convention together. I went to support her. And one day she went off to a group and she came back and she was just lit up like a Christmas tree. It's like, wow, what happened? How was that workshop? She says, I don't know, but I found this woman we met and her husband died the same way Bill did, outside, and just collapsed. And it was like, she didn't have to explain to that person any of the grieving process that she was going through. They both had like an instant bond. So that's why I know the relator is really, really vital. The other is a regular friend, and these, I'm sure, a dime a dozen, okay? Somebody treats you like nothing ever happened. They treat you like you never had a traumatic event in your life. It's like, come on, girl, yeah, let's go check out this movie. Oh, yeah, I haven't gone to a club in years. Let's go. So you need that person. That person serves that purpose of keeping your life moving forward. Don't need too many of them, but, one will do. The other one is a listener, someone who listens to you without interrupting or without giving advice. In the book, The Grief Journey, he talks about when he needs the number 3 friend, the listener, he'll say, hey, dude, you want to go with me and go out to dinner? I'll pay for your dinner. All you have to do is just be quiet and listen, but you can't say anything. You can't say anything. So you need that person that just listens. I'll just stop there. You need that person who's a listener. And then you need a truth teller, not in the vein of moving on, but calling out your blind spots gently, guiding us back to ourselves. And what I mean by that is somebody that can say, like, hey, Bonnie, since that event happened, I noticed that your hygiene's slipping, or when I take the trash out, you've got a lot of wine bottles in there. So somebody that just reminds you gently, though. So just take a minute. We'll go to the next slide. Just take a minute. When we talked about those 4 friends, is there someone that comes to mind for you who's your support? Somebody that you could call on? I use the term a ride or thrive friend. Somebody that you can call on, like a grief buddy, like, I've been just so depressed. This grief has me so down, but I really want to go to that party, but I don't know how I'm going to hold up. I may need to leave suddenly. And I call this your grief buddy. And they say, yeah, I'll go with you. And we'll have a high sign. If you can't take anymore, just do whatever, and I'll make excuses for us to leave. So you just think about that. Just stop and think that we are very, very social creatures, and we need each other. We need each other. And if you're not in grief, do you know someone who is? Can you just call them? And we'll go to the next slide. I'm not sure we're going to have time because I think yeah. Okay. Yes. So I want you to know that when I say call someone in grief. So many people say, I don't want to call. I don't know what to say. I don't want to make them feel worse. I don't want them to feel so bad. I want to be able to say something to make them feel better. And here's what I say. There's nothing that you can say to make them feel worse. they do feel bad. There's nothing that you can say that's going to take it away or help it. But you know what will help it? It's just your presence, just your being there with someone. And I'll just do a couple of these, and I won't take too much more time, but just some of the language. I'm trying to provide language for us to be able to use. So instead of saying to that grieving person, look on the bright side, how about just try, of course. Oh, right on time. Yeah. You could say, of course. That's all you have to say. Remember, sometimes less is more. Instead of saying you're being too sensitive, can you try, I can see how you got there. I can see how you got there, girl. Yeah, I understand. I can see that. And instead of saying they wouldn't want you to feel, just try, it makes sense that you feel. Oh, okay. All right, then we'll go through this. Okay. So instead of saying they wouldn't want you to feel, just try, it makes sense that you feel. It makes sense that you feel whatever they have told you, to just validate that, because that's what you're doing. You're validating. Remember when I said grief needs to be heard, validated, and shared? So you're validating what they're feeling. Yes, yeah. So permission blocking versus permission granting. So permission blocking, when you're sitting with someone that's grieving, permission blocking sounds like, aren't you over that by now? Okay. You need to be strong for others. I can't believe you're this upset. It was just a dog, a grandparent, a graduation ceremony. So that blocks them from sharing what else is coming up in your conversation. And so permission granting sounds more like, let's sit with this a moment. It's okay to feel that way. It's okay. But this, it sounds really hard. If you could have anything right now, what would it be? And I want to remind you that this is okay as well. Honoring and creating space for your grief. From others, you could ask for what you need. You could, sometimes we have to say, can you acknowledge that this is a really hard thing to go through? But I'd rather you tell me it's okay to have these feelings than the one that you say, you should have moved on. I don't know. It won't be like this forever, but I wish you could validate what I'm going through today. And I do want to turn to, if we're talking about you, we're talking about you being in grief. I want you to ask yourself, where can I be kinder or gentler to my grief? How can you be kinder and gentler to your own grief? Where am I feeling trapped or muzzled? If life, my friends, my job gave me a permission or a pass, what would that look like if they gave you a pass? Oh, they can't. Oh my gosh. You mean I have to start over again? Oh my gosh. I don't think so. Okay. I apologize for that. This is just for yourself. I'll cut to the chase with this one for yourself. Here's what I tell my clients. If you're in grief, treat yourself like a newborn baby. Would you ask a newborn baby to get up and go to Walmart and get, I don't know, a 6-pack or something? Would you have that? Would you ask a newborn baby to get up and make a brunch for friends to come over and visit? It's like, no, I want you to really know that grief is a very sacred and a transformative time for you. So treat yourself with some kindness and some gentleness. And just a gentle reminder, always ask open-ended questions to allow for the opportunity of free-flowing dialogue. And what you can do that really helps with grief is designate an object to represent your permission to grieve, like a stone, a coin, or a piece of jewelry. You could just make a touchstone for whatever it is, even if it's for what I refer to as a living loss where no one died. The home that we had in California, I love that house. And I always say that house loved me. We had a love affair. So I have this picture. I do something called soul collage. So I made a collage card from that house. And anytime I'm feeling sad about it, I just get my card out and just feel such gratitude that I had the opportunity to live there. And that house, as I said, loved me as much as I loved it. But you can use a button, you can use a stone, something you just put in your pocket, maybe on a day that you're really feeling really like it's just hard to get out of bed. That's your reminder of, yes, of the loss, but then there's a gift attached to that. And okay. What I want to say about this, when I said can you go back just one? Transformation. That grief does transform us. And what I want you to do, let's go for it again. Oh, another one? Yeah, there you go. So this would be a journal prompt, and you can just take this home to do this if you want, if it resonates. And this is a reflection. Because we want to, if you can, hold in your mind's eye or just bring to heart something that you lost. From this present time to maybe a year ago, or something that you lost a couple years ago, or maybe even in childhood, or maybe 10 years ago. And just holding that. Wants to come in. Or maybe someone's ancestor. I don't know. That's the past coming in. And I want you just to reflect on these 3 little prompts. So choose one. Since you've been gone, or since this happened, I realize. Open-ended. I now do. I am on the recovery too. And if I was answering this from 5 years ago, from 2020, I realize that grief has a superpower, and it's healing. Grief is transformative. I now am so honored to be sharing and holding that energy to discuss grief and being comfortable with that, so that I can make space for others to be comfortable with their grief. I was going to add, I felt that, and this helped me realize that my own reflection is that I came into my life to be of service, being a nurse, being different service roles. But my purpose in life is to serve, but not serving like a doormat, but serving like a queen, where I let my light shine, which then encourages you to let your light shine. And one last quote. And so, as I've said, self-care while grieving is just vital. Just vital. Be gentle with yourself. Rest. You will need more than usual. Do you know that when you're in grief, that initial stage when you get the information, did you know so many people talk about brain fog? Anybody can relate to that brain fog where you just can't think, can't put things together? The science has showed that it's 10% of your brain is being used to process this grief, to process this loss and put it in perspective. So no, you're not at full capacity. You're not full throttle, as they would say. So rest, and you'll need more of it. Eat well, nourish your body. Dr. Sam will approve that, right? Yoga poses for grief, child's pose, corpse pose, our legs up the wall. Those all help reset our nervous system. Avoid alcohol and other drugs, or at least in moderation. Maintain an 8-hour-a-day work schedule if you work. and accept help from others. People really want to help each other. Please allow them to help you. Just allow them. And I know there's so many times people will say, oh, what can I do for you? And the grieving person will say, oh, I can't think of anything. But if you're the griever, start making a list of what you need. Like maybe I need somebody to pick up the dry cleaning. Maybe I need someone to take the dog for a walk. Maybe I need somebody to pick up something from Walmart. And that way, if you have a list, when people ask you, then you will have something. You could say, yeah, I really need some help, picking up the laundry. And my last thing that I'll leave you with this is that we all have talked to people that have a loss. And we always say this, and we mean it from our hearts. We mean it from our hearts. We say, call me if you need something. I'm right here. How many people have said that? Call me. I'm here for you. I'm right here. Well, I'm here to tell you, they're not going to call you. They're not going to call you. So let's reframe that. Let's start by saying, I know that this is a difficult time for you right now, and you may not be able to think what you need, but I'm going to call you. Today is Sunday. I'm going to call you on Wednesday to see how you're doing. You be the one to call and initiate the interaction. So I think that's it. Let me see. But one more slide, but I think that's just about me. Yeah, I do have a podcast on New Thought Media, and it's on Mondays at 2, and it's Your Doula for Grief. I also have written a book, Blindsided by Grief. And this is just, 5 essential components that's necessary to help you endure the healing journey of grief. So know that grief has that superpower, and that superpower is healing. So thank you. Any question? Any questions? That doesn't. Any questions? Any questions?
Are there any questions or comments that you want to make?
Well, if there aren't any questions, I'm going to pat myself on the back because I must have explained everything to the umpth degree that I didn't leave you hanging with questions. So anyway, my tagline for grief is, don't do grief alone. Don't do grief alone. If you take nothing else away, just don't do grief alone. Thank you. Thank you. Okay, this and the microphone. The microphone.
Thank you.
Oh, yeah.
Likewise. Thank you so
Yes,
much.
yes. Grief is my jam.
Well, and correct me if I'm wrong, but I have several patients that they always repeat and repeat and repeat the same questions, and they feel so guilty for doing it. And I'm like, don't feel guilty for it. It's questions that you need to listen to the answer again, and then just, relearn how to leave this process.
Right, and sometimes when we have so much information that we're taking in, like Dr. Sam's president, you're going to need to keep asking the same question until it's clear. So what is that? The only silly question is a question you don't ask. So if you remember that, then you'll be like me, always asking questions.
All right. I'm going to go on. You're welcome, Bonnie. Thank you. I'm going to turn on the light right now.